in this session. I really enjoy talking about drug reactions. I think that nowadays when I see someone with a lichenoid eruption or even a pityriasis rosea-like eruption, the first thing I think of, I don't have a advancer. First thing I think of is the person on any medication that could be causing this eruption? Thank you. Thank you. I don't know. Okay, now, okay. I have no conflicts of interest. This is something I took out of an algorithm that I wrote many years ago, and the idea was that what were the things I asked a person that I thought they might have a drug eruption, and I was interested in knowing, was it something more serious or less serious? So obviously a blood pressure is good because of toxic shock, but most of those people don't come to a derm office. I always like to ask, do you have any flu-like symptoms? That's very important for me. Do you have a fever? Do you have arthritis? I also want to circle lesions and make sure that it's not just urticaria as opposed to an urticarial drug eruption. But I think one of the most important, what I call pertinent negatives, is that anytime I approach someone with a drug eruption, I always write down no pustules, no vesicles, no dusky centers, no fragile skin. And the reason I do that, in addition to no mucosal involvement, is that the most important thing that I'm excluding is early SJS or sometimes DRESS. And I'm trying to get a handle on whether the person just has a simple morbilliform eruption or whether I need to get nervous. And so it's very important whenever you approach someone with a drug eruption that you say to yourself, what are my most likely drugs? What are my least likely drugs? And be honest when you don't know and need to look things up. And here's what I mean by that. This is a typical drug chart. Now, you don't have to be so compulsive that you do the shading in red. This was one of my chief residents who was particularly compulsive and would do the shading in red. But nonetheless, you have to say to yourself, how long has the patient been on the drug? I mean, are we in the right window for a 3 to 10, say 14-day window? Are we in a longer window when we think about things like DRESS? Or do we have a high probability drug? I think it's also important to rank when you see the drugs that patients on. Are they high probability, moderate probability, or low probability? And when they're low, I throw them out. Whenever they're high, it's easy. Penicillins, cephalosporins, aromatic anti-epileptic drugs. Those are the easy ones. For me, the hardest part is the moderate group when I don't have a high probability drug. When you have a high probability drug, it's easy. When you have no high probability drug and have to deal with moderate probability drugs, I think it can be difficult. Now, today we're going to hear about DRESS. Today we're going to hear about SJS-TEN in later lectures. To me, those are the two that I pay attention to. In addition, obviously, we're going to hear about the difference between vasculitis and thromboses, and that's also important to all of us. There, though, we usually have purpuric lesions. We're less likely to be in that, is this a bad drug rash? And so that, to me, is in a different box. I don't worry that much about angioedema because that usually presents to the emergency room, not to the office. Sometimes, obviously, it's misdiagnosed, but it isn't something where we're on the front line. To me, we're on the front line of SJS-TEN, DRESS, and sometimes acute pustular reaction. Now, this is my way of thinking about middle of the night, it's midnight, and you're called by a first-year resident. And the idea is, what do I not want to miss? And to emphasize, to me, when I'm thinking about non-infectious diseases, what I don't want to miss is along the bottom. The infectious diseases are across the top. And the non-infectious I don't want to miss is DRESS, early SJS-TEN, vasculitis thrombosis. Kawasaki's is a special case for children, and we're really not sure what exactly brings that on. But nonetheless, those are my considerations. I also want to make the point, as we set the stage for today's section, that we're not always so clear what we have. I'll do the clicking thing. It's not always, no, please don't, somebody's touching my stuff. No. Okay. It's always not so clear. In some patients, we'll have people who have really bad HF, and they'll get so many pustules that they all become confluent, and a large area of the skin will fall off. And so some people will think the patient has TEN. In addition, we have people with DRESS. I want to emphasize that those people can get vesicles, and those people can get pustules. So it's not always so easy to put everybody in a box when they have this group of diseases. Now, TEN, we're all aware what it looks like when it's really bad. Obviously, it's a dermatologic emergency. And when I was training, we were told that the major differential diagnosis was, is it SJS versus TEN, or was it a young person or maybe an adult with renal disease, and was it possibly staph-scalded skin syndrome? And all we had to do was a simple cryo-stat section, and we would make the diagnosis. But I think that was a bit naive, in the sense that, in my opinion, the differential diagnosis of TEN is actually much more expanded, in the sense that it does include severe acute graft-versus-host disease, the TEN-like presentation of lupus, systemic lupus, the vancomycin-induced LABD, toxic erythema of chemotherapy. We're going to hear a little bit more about chemotherapy reactions today. HF, bullous pemphigoid, and in preemies, congenital candidiasis. Now, the ones that are in green are in special situations. What do I mean by that? If you have a premature infant, if you have chemotherapy, it's usually self-evident, and if you have a patient who's had an allogeneic stem cell transplant. Now, a minute about the systemic lupus patient who presents just like TEN. You need to know about this. Sometimes there's a problem because they're also on a non-steroidal anti-inflammatory drug. It can complicate the picture, but you need to remember that in your differential diagnosis of TEN is this like reaction, TEN-like reaction of systemic lupus. Now, the patient may have recently had their immunosuppression decrease, or it may arise de novo, but it can definitely mimic both SJS and TEN. Now, here I have 5 pictures of people, none of whom have TEN, but yet you might think they all have TEN due to a drug, but none of them do. So I'll have you take a minute, think about what you think these patients have. You did get a chance, you who were here early when they went through my lecture, that the answers came up on the screen, but I hope you were too busy on your iPhone to have seen it. So here we go. These are the diagnoses. Bullous pemphigoid, congenital candidiasis, the severe version of the toxic erythema of chemotherapy, the vancomycin-induced LABD, and I want to warn you, you may have a patient who has TEN, and then because of concern about the break-in barrier, they're put on vancomycin to protect them against Staph aureus, or even become bacteremia with Staph epidermidis, and they'll be on vancomycin, and then you'll think they'll have a recurrence of their TEN, when in fact what they now have is on top of that, they now have the vancomycin-induced LABD. And so you need to then do direct immunofluorescence